Welcome to the CodeCast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast Podcast. Today, my name is Terry Fletcher. It is the 160th episode of the CodeCast, and we are well into November. And in keeping what is the rush to get training done before 2021, I'm going to use my specialty coding spotlight to focus a little bit on the E&M 2021 new rules. So I know many of you have purchased and have already listened to my 3-part webinar series, which is available. All 3 parts are available now, and it's on demand, and you can find it at terryfletcher.net if you haven't already registered and purchased it. It also has CEUs available. You have to take a test once you listen to part 3, but just let me know if you need those. But here is going to be a sneak peek of what you would learn by taking that webinar series. And remember, these rules change for office and other outpatient visit codes 99202 to 215 in about 6 weeks. So it's time to get serious about training for these services, and this will be one way to do it. So I'm just going to give you a couple of examples just so you know kind of where I'm going with the in-depth training. But I just want to make sure that you had at least an understanding of what you're kind of in for when we get into some of the bigger information and some of the things that payers will be looking for. So this example will be a 99202, and I want to explain kind of what you're looking at from a time perspective, and then I'll let you know what it would have been had it been medical decision-making looked at. So you'll be able to kind of see both. And I do that throughout my webinar series as well, just so that you can see what their options are. So here's a patient that presented with pain in the forehead, green nasal discharge, and fever. So this probably is more like a primary care internal medicine encounter. So visit type new patient, chief complaint. So again, patient with her complaints today where she's got nasal discharge, she's got pain in the forehead and fever. Patient states that there has been a constant dull ache behind her eyes for a week. And yesterday she started to feel feverish and had pain under her eyes with darker green mucus nasal discharge. Okay, so you're going to hear me say a couple things that I think you're going to be like, oh, I didn't even think about that if you've already started your training. So that took about 5 minutes to go over with the patient. Then there was review of systems. They did a brief constitutional, so fever, not taken at home, but they took it at the office. HENT, nasal discharge, pain in sinuses, past medical history, no known allergies, non-contributory medical history. Patient has never smoked. She works as a nursery school teacher. And then we went into the exam. So vital signs, height 64 inches, weight 140, and temperature was 101.6. A constitutional patient appears her stated age, healthy and well-developed young woman in no acute distress. Eye exam was done, and then a ENMT was done. So lips appeared normal and healthy, gums normal, palate normal in appearance, the normal oral mucosa, normal with no thrush, tongue is normal, and nasal pressure was noted on the exam, and chest was also clear, respiratory was also clear to auscultation. That took about 10 more minutes. So now we are up to about 15. Assessment, so the patient has acute sinusitis. Prescription and skincare management recommended. Also, they added Mucinex D, rest, drink plenty of fluids, and rest until 24 hours after temperature is normal. Note given to stay out of work for the rest of the week. And that took about another 7 minutes. And the patient was given a Z-Pak prescription and sent electronically to her pharmacy, which took about 7 minutes as far as getting that all together. So how do we code for this? Well, remember the history and physical isn't going to have a bearing on how you level a code, but I would look at that to make sure that it was problem pertinent and medically indicated. So basically what you're looking for from an auditing perspective is how did you get from A to Z? So from the time the patient called the office and they came in for the encounter, then how did you get to your medical decision and plan of care to give a prescription or add tests or, tell the patient what to do. So you still have to have a medically appropriate exam and history, but you don't have to have the bullets as we used to before. So if you're coding by time, you had history and a review of symptoms and a medically appropriate exam, that took about 15 minutes. Then counseling and education of the patient, that was about 7, and then ordering medications was about 7. So you had 29 minutes. So based on our time range that we have for 99202, that is 15 to 29 minutes, that's where you would be. Now, if this was done based on medical decision making, you would actually have coded a 99203 because you have prescription drug management, you had enough on the counseling, and there was enough information basically, again, in the medical decision making on what you did to get to a low level. That's where you have to decide, are you going to bill this based on time, or are you going to bill it based on medical decision making? And you have to be able to know how to capture your time on all services that you are looking at. Otherwise, that can be a problem. So let's take a look at another one. So this one, again, may be primary care, but this was also, it could be for dermatology, for a skin area. So this was a patient that had a lesion on the shoulder. This is a new patient visit. So patient presents today with a new concern about a lesion on her shoulder. Patient states there's been a change in the lesion over the last 2 years. The lesion worsens with scratching and rubbing. The lesion sometimes disappears and sometimes worsens, and then no treatment to date. So review of systems, there's really no symptoms except for the skin issue. No known allergies, no family history was taken, and the social history was just the patient never smoked. They have that took about 3 minutes. And then on the exam, constitutional, so stated age, healthy, no acute distress. Did an eye exam, ENMT exam, upper extremities, fingernails, nails, everything looks normal there. Skin, however, they also did skin. Examination of the shoulder area indicates the patient's got some lentigenes and actin damage and seborrheic keratosis. So that was about another 5 minutes. So the assessment was the L82.1, the seborrheic keratosis, and the discussion with the patient about the etiologies and natural history and treatment options regarding that diagnosis and acne. They put in there that time was 19 minutes. Prescription and skincare management recommended and apply, was basically they gave them a ointment, and it's basically said apply to the affected area twice a day for 8 weeks, and that took about 1 minute to explain to the patient. And then basically the patient's going to try it, then they'll let them know. And that was about and updated the patient's medical record, another 2 minutes. So if we base it on time here, this is going to be something you want to be clear of. So the rationale here for time, we had obtain a history and a review of a separately obtained history. That was 3 minutes. A medically appropriate exam and or evaluation, 5. Counseling and education, the patient, family caregiver, 19 minutes. Order medications, tests, or procedures, 1, and then document clinical information in the medical record was 2. So this was a 30-minute visit. So based on time, which is now the threshold, or I should say the range, for a new patient level 3 is 30 to 44 minutes. So you hit a level 3, 99203. But if this was based on medical decision making, you would still be straightforward just for the lesion on the shoulder, and that would have been 99202. So sometimes time is better, sometimes it isn't. But remember, the activities that count towards time could be preparing to see the patient, reviewing any tests, obtain and or reviewing, separate obtained history, perform a medically appropriate exam or eval, counseling and educating the patient, family, or caregiver, ordering medicine tests or procedures, and referring or communicating those tests that you did not bill for before to the patient or other healthcare professionals, and then document clinical information again in the record, and then the independent interpreting of results. Make sure if you do that you're not billing that interpretation as well. So you can have one or the other. And then if there was a care coordination, that cannot be billed because that would be part of that discussion. But you can see how we can flip both of those based on what's going on with the patient, and you have to just be careful to, if you're going to time it, everything needs to be timed. At the very end, it would be really hard just to say total time of the visit, because you not only get total time, but you also get time spent with non-face-to-face if the non-face-to-face was by the provider actually billing for the service. Now, do you have to break up the time based on each area, the exam, the history, all that? You don't, but you better be ready to support it should anybody ask you about it, because if you don't if you're not able to support it, then it's really going to be hard to, basically say, okay, this is what we did. So here's one that I have that comes in now all the time, and I try to get offices in 2020 not to code for this, but this is something that came in recently. So an established visit seen by the PA, and mother brings in a 3-year-old girl in today for a note to return to daycare. So 2 weeks ago, the patient was kept home, and basically they want them to return now. And it was just because the patient just had a little discoloration of skin that turned out not to be anything. So they just came in, did a quick check on that, did a quick look at an exam there, and the patient everything was resolved. There was nothing else. It looked like it ended up being a scratch. Total time of history and exam was only 5 minutes. And then basically reminded the patient to make sure they wash their hands, do not scratch any sores or if they, cuts or anything. And then the daycare recheck was issued today, and then that took another minute. So how do you code for that? Established patient coming back. Well, if that patient was actually seen by the practitioner and you based it on time, so if it was PA or a physician, you would actually get 10 to 19 minutes. But if you base that on medical decision making, and if it was performed by the clinical staff of just saying, okay, everything looks good, there's no issues there, then that's really a level 1, and you might have a hard time to try to code a 99211 if it's just for paperwork. Make sure, if that is the scenario in your office, that the patient and the mother was brought back into an encounter room so that there was some kind of a clinical visit, not just an administrative visit. I see that happen all the time where we get these administrative visits that are being tried to be billed as E&M, and you can't do that. Return to work slips, return to daycare slips, return to school slips, unless there's some kind of a problem pertinent history and exam to show that things have resolved. But I do see that every once in a while, and we just have to be really careful with that. Okay, so I want to get into my coding question today. And this is one, so this is actually continuing with the E&M office visit for 2021. It's actually an update, an add-on code. And I know some of you have heard about the new, 99417. It used to be a placeholder where we had just XXXs after the 99. But now we have a prolonged code. And one of the questions was, would the provider have to reach the full 83 minutes to bill a 99205 with a 99417? Well, let me explain what that means. So the new 99417 code is an additional 15 minutes that can be used only with level 5 services in 2021. So they're basically, it's saying that it's above and beyond that 99205 or 99215. Now, here's something you need to know that we found out just this last week from Medicare. And I knew, Medicare, it's funny. It's like they say we're working with CMS or CPT, we're working with AMA, and they do it right up to the point where then all of a sudden they're like, except for that. And sometimes it's buried. But what they talked about in some of their last information was, so for CMS, you would need to meet a minimum. So for Medicare, of 89 minutes for a new patient visit before you can add that 99417 code. Now, if it's just for a private payer, CPT, so it's just a Blue Cross Blue Shield or United Healthcare, you have to meet the 74 minutes. So here's what CMS is saying. They're saying we want to see 15 minutes added on first to that code to see, that you actually did the full 15 in addition to the time-based code for the 99205 or 15 before you can add it on. But CPT AMA says you just have to hit the end of the range of the 74. So you have to hit at least that, and any amount of time that you go into past that, you can add on that 99417. And they've got some code ranges there of how much you have to hit. I think it's at least 5 minutes before you can get there. So that's a different rule that Medicare basically, makes it a little tougher to hit the time requirements. Also, remember, you can only use that prolonged service code if you're using time to level your code on a level 5. So if you're not using time to level your code, then that is not something that you would use. If you're using medical decision making, you don't get it. So there are other services as far as a new complexity code and things like that, but you would need to really attend one of my or all of the part 3 of the 2021 E&M webinar series. So we just want to make sure that you had an idea of how it was going to be taught and really what we're looking at there so that you can make a decision if it's something that you want to participate in. If there's something that you've already done that you're happy with, that's great. But just know they're available now, and there's 3 parts. You get a PowerPoint with each one. You get the AMA grid. And then also for the last one, we offer CEUs. So hopefully it's something you're looking at. Okay, so my coding question was brought to you today by Pure Leaf Real Brewed Tea. Real tea done right. pureleaf.com. We appreciate them. I like those. So I'm going to end with my personal tidbit this week. So yes, my Steelers are 8-0. I actually am recording right after our game on Sunday. And it was ridiculous. I'm still hyperventilating. Believe me, one of the things I know I mentioned to you guys before, I podcast a lot. So I have different podcasts, not just my CodeCast, but I also have one called The Business Collective, and that's about going from an employee to entrepreneur. So you can find that. It's Business Collective by Terry Fletcher. But I also do a weekly podcast for a site called Steel City Underground. And actually it's owned by my producer for this podcast, Joe Kuzma. And he allows me to do a weekly podcast, and it's called What the Football. So WTF. And it's every week. And so I'm still hyperventilating from this week, but we do it every single week, and it's going to be crazy. But we are 8-0. But one of the things I was going to mention is that I actually record all of my Steeler games so that I can go back and take a look and then, include it as part of my podcast information. But I don't want to rewatch this game. It was right down to the wire again. And we just played terrible. But we were playing the Cowboys, who are on their 4th string quarterback, and they have holes in their system, but they looked like they've been playing their hearts out forever. And we did win, but oh man, it was ugly. So anyway, I was just happy with the distraction. Football is my thing when I'm not working, which is all the time. But with all the craziness going on in the world of politics and the pandemic and you name it, I'm just so happy to have football. So I don't know what your hobby is, but embrace it right now with everything going on. Also in Southern California, we finally got some rain here over the weekend. So hopefully that'll put out the rest of the fires for us, because we are still smoldering, but we are happy for some rain. Okay, so everyone, make it a great week and a great day, and hopefully that gave you some insight into some of the 2021 E&M guidelines, and we'll talk to you soon. And I'll see you next week on the CodeCast Podcast. Thanks again for listening.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.